So hi everybody, this is our lecture on inflammatory bowel disease, HIV, and rheumatoid arthritis. I will be covering everything I was planning to cover last Tuesday in this lecture, and anything that I don't finish covering in this lecture will be covered next week in class. So know that you're not going to miss any content or any concepts that are going to be on the next exam. Always make sure you're looking at the class outcome slides. These will help you not only study for the course exams, but for your NCLEX and for your ATI, Med-Surg ATI at the end of the semester. So inflammatory bowel disease is a chronic disorder that's characterized by chronic recurrent inflammations of the intestinal tract. Basically, you'll have periods of remission interspersed with periods of acute exacerbations. And these acute exacerbations are unpredictable. You never know when they're going to flare up, and they can be mild or they can be quite severe, requiring hospitalization. So it can be quite disruptive to your life. Think about how you choose the activities you're going to do and the work you're going to do. When you're living with a chronic illness that's unpredictable and can be quite severe. The cause is generally unknown. We're going to discuss some predisposing factors, and there is no cure. Our treatment relies on medications to treat inflammation and to maintain remission, and also we'll sometimes have to do surgical resections to control the inflammatory bowel disease. There are two types. Ulcerative colitis involves inflammation of the colon and rectum, and Crohn's disease can involve any part of the GI tract from mouth to anus. So again, ulcerative colitis is confined to the colon and rectum. Crohn's disease can involve any part of the GI tract. It can occur at any age, but it generally peaks in late teenage and young adult years between about 15 to 25, and there's a second peak in diagnosis when people are in their 50s. It equally affects males and females, and it is more prevalent in folks of Northern European descent and in industrialized regions of the world. So it is an autoimmune disease. Antigens initiate the inflammation, and the actual tissue damage and the actual symptoms come from an inappropriate sustained immune response. And although we don't know the actual cause, we believe genetic, environmental factors play a significant role, because we know that if you have a family member with inflammatory bowel disease, you're more likely to develop inflammatory bowel disease. If you have other inflammatory disorders such as psoriasis or MS, or other genetic disorders such as cystic fibrosis, you're more likely to be diagnosed with inflammatory bowel disease. Diet plays a significant role, but we know that if you eat a diet that's high in fats and meats, that you're more likely to develop inflammatory bowel disease. And we know that if you have a high fiber and fruit intake, you can reduce your risk for Crohn's. We know that high vegetable intake reduces your risk for ulcerative colitis, and that oral contraceptives and NSAIDs seem to exacerbate Crohn's. So some gerontological considerations, like I said, there is a second peak when people are in their 50s. More older patients benefit from surgical resections when they have Crohn's. It will reduce their exacerbations. And of course, older adults are more vulnerable to inflammation overall, and they're more vulnerable to fluid and electrolyte abnormalities that result from the signs and symptoms and effects of ulcerative colitis and Crohn's flare-ups. Both types of inflammatory bowel disease increase the incidence and severity of C. diff infections, so that's important to know with elders. There's an increased risk of bowel strictures, perforations of the bowel, and an increased risk of colorectal cancer in both types of inflammatory bowel disease. And in Crohn's disease, people have an increased risk of small bowel cancer. And again, look at elders, the drugs they're taking, and see if any of the drugs they're on, any NSAIDs or estrogens that they're on that might be increasing their exacerbations. So ulcerative colitis usually starts in the rectum. It spreads in a continuous pattern up the colon, but it is limited to the colon and rectum, and there's minimal small bowel involvement. So you don't have the you have minimal problems with malabsorption and nutritional deficiencies because the small bowel is not involved, and you have minimal issues with weight loss as well. You do have diarrhea with ulcerative colitis, massive fluid and electrolyte losses, and when we're talking about a mild exacerbation of ulcerative colitis, we're looking at 4 bowel movements a day. A moderate can be 10 bowel movements a day, and a severe can be 10 to 20 bowel movements a day. And these are bloody, they're mucousy, so you can see why you're going to be possibly seeing anemia and dehydration and the tachycardia that results from the anemia and dehydration. These people are going to be tired. They may have a fever. They're definitely going to have bloody stools, and they're going to be in constant abdominal pain. Sometimes with ulcerative colitis, your risk for perforation with this is increased because sometimes you'll develop toxic megacolon. Toxic megacolon is a dilation of the colon where they can retain 30 to 50 pounds of stool. And if you've never seen a picture of it, go online and Google this, because you will see why this increases their risk for perforation when they've got toxic megacolon. So that is a risk with ulcerative colitis. So basically you get multiple abscesses that develop in the intestinal glands, and these break through into the submucosa, leaving little ulcerations that destroy the mucosal epithelium and cause the bloody diarrhea that we see with ulcerative colitis, that results in those fluid and electrolyte losses, protein losses, and they can also develop pseudopolyps from this. So Crohn's disease, like I said, can involve any segment of the GI tract from the mouth to the anus. It is common to have a involvement of the small bowel. The distal ileum and the proximal colon are the most common sites, and the entire thickness of the bowel wall is involved. And I want you to see this picture. This is a picture of what we call skip lesions. It's a cobblestone appearance. This is classic Crohn's, where you have healthy tissue interspersed with inflamed areas. So it kind of has that look of a cobblestone street. So with Crohn's, diarrhea is common. You'll have cramping abdominal pain. You will sometimes have rectal bleeding, so you will probably see that, but it's not like it is with ulcerative colitis, where it is just bloody diarrhea. Crohn's does have some rectal bleeding, but not like ulcerative colitis does. You will see malabsorption and nutritional deficiencies with Crohn's because of the involvement of the small bowel, and you will see perianal fistulas and abscesses in 1/3 of patients who have exacerbations. So these folks do experience weight loss. Toxic megacolon is rare in Crohn's, but you do have an increased risk of bowel perforation because of the entire thickness of the bowel is involved, and you can get microscopic leaks that allow the bowel contents to enter the peritoneal cavity and cause sepsis. So there's a great table in your book and some pictures in your book like this one, and here's another example. Let me go back. There's a great table in your book on page 945 that compares and contrasts ulcerative colitis and Crohn's. So make sure you understand the 2 different types of inflammatory bowel disease. And both of them can have mild to severe exacerbations. They're both unpredictable, and you will see all of these side effects and complaints in both of these, to different degrees. And here's a little slide comparing them, but again, use your book. Go to that table in your book because it's far more comprehensive. It's on page 945. So complications can be intestinal, localized to the GI tract, and we've talked a little bit about that, but they can also be outside the intestines. There can be systemic issues that can happen. What happens, there's a table on page 946 that talks about these complications. Basically what happens is circulating cytokines that trigger the inflammation in the intestine also trigger inflammation in the joints, eyes, mouth, kidneys, bone, vascular areas, and skin. You can develop inflammation and scarring of the bile ducts that can lead to liver failure. So you can have significant involvement outside the GI tract as well. So diagnosis involves ruling out other diseases with similar symptoms because, you know, a lot of people come to the hospital complaining of diarrhea and fever and fatigue. So you're going to do a very detailed history and physical examination to find out if they've ever had these symptoms before, if so, what was going on. You're going to try to rule out other things. You're going to get lab work. CBC is going to tell you if they've got any iron deficiency anemia from the blood loss. Elevated white count could indicate perforation of the bowel, and sepsis or toxic megacolon can cause an elevated white count. You might see decreased albumin, decreased electrolytes, elevated sedimentation rate, and C-reactive protein. And your stool sample is going to be probably show blood, pus, mucus, and other signs of infection. Imaging studies that we do are a barium enema with a small bowel series of x-rays so we can look and see if what's going on in there. We'll sometimes do a CT or an MRI. You can get a colonoscopy. Capsule endoscopy is often valuable in this because it can get a really good view of the small bowel, the entire bowel from GI system from mouth to anus can basically be photographed from the inside with a capsule endoscopy. So I've seen them do colonoscopy along with the capsule endoscopy and sort of look at the results from both. And see, you know, maybe we can see more here, maybe we can see more there to try to figure out what's going on. They'll almost always biopsy to see the tissue, to see if it's a full tissue length or full tissue width, and they can diagnose Crohn's, or if it's just a mucosal layer of tissue involvement and it's ulcerative colitis. So we're going to do all of these studies just to kind of determine what's going on and is it Crohn's or is it ulcerative colitis. Our goals of treatment are to induce and maintain remission. We're going to rest the bowel. So when we're resting the bowel, we'll often have an NG tube in. They won't be eating anything. So as nurses, we have to think about how they're going to get their nutrition. Are we going to ask the doctor for a TPN order? What do we need to do to make sure they maintain their nutritional levels? Or what are we going to do to correct malnutrition? Do we need to give some electrolytes? Do we need to give some IV iron? All of those things that as nurses we're thinking about. We're going to alleviate any stress that they may be having. We're going to keep their room quiet and let them rest as much as possible. We're going to combat any infection that might be going on with our IV medications, and we're going to relieve their symptoms that they might be having that are associated with having 15 to 20 bowel movements a day. Think about that. Their skin is probably going to be excoriated around their anus. They may have some hemorrhoids. So sometimes things like sitz baths or skin barrier creams can feel good. Sometimes compresses with ointments. I've seen witch hazel used. You don't want to use soap because that's not going to feel very good, right? So just think about things like that you can do to not only help maintain their dignity, but help them feel a little bit better while we're controlling this inflammation and infection and getting them back into remission. There are 5 major classes of medications that we use when we're inducing and maintaining remission in folks who have inflammatory bowel disease. Aminosalicylates are used to suppress pro-inflammatory cytokines. to reduce the inflammation, and those are usually given as a combination of oral and rectal therapy. We're going to look at our antimicrobials like Flagyl, Ciprobiaxin. These are going to prevent or treat an existing infection. Steroids, we all know if we want to decrease infections, corticosteroids are the way to go. We're going to decrease the inflammation and achieve remission with those, hopefully. We're going to give these for a short time, and we will probably, you'll still see them given IV as well, but often with inflammatory bowel disease, you'll give these rectally. They'll be in a suppository or foam formulation, and you'll give them rectally because this will reduce the inflammation in the bowel while decreasing the systemic side effects of the steroids. But remember, the steroids are only given during a flare-up. They're not given to control and maintain a remission. They're given to control the flare-up and put us into remission. Now, if once the steroids and the antimicrobials and the aminosalicylates have achieved remission for us, then these folks are going to go home on immunosuppressants like Imuron. These maintain remission. They have a delayed onset, so they're not useful during flare-ups, and the most common one you'll see is the Imuron. You will see methotrexate if we can't control the flare-ups, like say we just can't get this person off steroids without them having a flare-up, then sometimes you'll see them given methotrexate if they just simply can't control, they can't maintain their remission. But usually you'll see Imuron, sometimes you'll see methotrexate. Those are to maintain remission. And then biologic therapy, these are drugs like these are drugs that either inhibit the cytokine anti-tumor necrosis factor or they inhibit leukocyte adhesion. There's two categories of these. One that the anti-tumor necrosis factor inhibitors like Remicade or Humira. Remicade is given IV. This will induce or maintain remission in Crohn's, or sometimes in people who have draining fistulas who aren't responding to other therapy, like say we cannot get them to go into remission and stay into remission with the immunosuppressants, then we'll move to the biologic drugs like Remicade, the anti-tumor necrosis factor drug, and Humira, which is also an anti-tumor necrosis factor drug, but it's given sub-Q. We don't go to these drugs first because they're very uncomfortable. They can increase risk for upper respiratory infections, UTIs. They cause headaches, nausea, joint pain, abdominal pain. They can cause opportunistic disorders like cancer, lymphoma. They can reactivate TB or hepatitis. So it's important if we send someone home on biologic therapy that we teach early signs and symptoms of infection so they can seek treatment quickly. So other than the cytokine, the inhibitors, the anti-tumor necrosis factor inhibitors, we also have the integrin receptor antagonists. These inhibit leukocyte adhesion, and these are only used for people who are non-responsive to the anti-tumor necrosis factor drugs. Just note that those exist. And finally, we've got drugs that we can use to reduce the number of bowel movements that they have. We can give them Lomotil to hopefully reduce the number of bowel movements per day, and we can give them vitamins and supplements to help improve our nutritional status and improve our iron. So 25 to 40% of people with chronic ulcerative colitis will need surgical intervention to control the disorder. Probably the most common surgery that we're doing now is a total colectomy, where they go in and they do a rectal mucosal stripping. This is a two-part surgery. They'll do the colectomy and the stripping in the first surgery, and during that surgery they'll create a temporary ileostomy, and they'll often have a what's called an ileal pouch, a little reservoir that they'll create there to allow them to control their defecation. And then usually about 8 to 12 weeks later, they'll go back in and they'll have the second surgery to close the ileostomy. What usually happens is they'll have about 4 to 6 stools per day for the first 3 to 6 months, and then it will start decreasing over time. So that's how they will help the cure if the medications are no longer working. They'll do a 2-procedure colectomy to allow the bowel to rest and also to strip the mucosa. The other surgeries here, you can do the third surgery here on your page, the total colectomy with permanent ileostomy. It's a 1-stage operation. We put in a permanent ileostomy. That's it. The anus is closed. They are not going to ever be continent again. They're always going to be using their bag. So the most common one is one where we put in a temporary ileostomy and then strip the mucosa. And then when all of that's healed, we reverse everything, and usually that resolves it. The one in the middle, I'm not even going to really talk about much because we don't use it much. Once in a while, you'll see an older patient come in who's got a pouch that they basically drain at regular intervals. And it's interesting because we don't do it much because there were a lot of problems with infection and leakage with those, but you will occasionally see someone who's got control over their ileostomy, and before you start wondering what the heck is that, just know that it's an older procedure that you will occasionally see someone come in and have a pouch, a stoma that they can control, which if you've never seen it before, you're kind of just wondering what it is. In Crohn's disease, 75% of patients will require surgery at some point. They will achieve remission with surgery, but there is a high recurrence rate. Many times they'll go in and take out strictures, and sometimes this is done on an emergency basis. Often it's done on an emergency basis with these folks. With Crohn's disease, they're at risk of developing short bowel syndrome. With short bowel syndrome, they'll have chronic diarrhea, and they'll be unable to meet their nutritional needs. They'll often develop anemias. So folks with short bowel syndrome will need vitamin B, IV iron, zinc, vitamin D, potassium. All of these will need to be supplemented. So just know that over the long term with Crohn's, most people will require surgery, and it can be quite it can be quite difficult because it's emergent, and if they have surgery, large segments removed, then they can definitely develop some chronic diarrhea with that. One thing about the stomas, on the previous slide, when you've had a stoma and you've got an ileostomy, just know that your stoma should be beefy red. When they first come out of surgery, they'll have some serosanguinous drainage out of it, and they may not be able to tolerate a regular diet. You need to start them with clear liquids, avoid high fiber foods, and watch that stoma to make sure it's beefy red. And you may need to supplement their diets for a while and give them enteral feedings until they're able to eat again. So just know that. So, you're going to need a lot of nutritional therapy with this person. You're definitely going to have a dietary consult, and you want to advance their diet without causing them to have symptoms. You're going to be watching their fluids and electrolytes, preventing malnutrition, and again, just everything that I think I've already mentioned here. And our goal is to, again, reduce the number and severity of acute exacerbations, to maintain a normal fluid electrolyte balance, keep them free from pain or discomfort, teach them about their medical regimen so they can be more apt to comply with it, and help them improve their overall quality of life. And again, when you do a nursing assessment, make sure it's fairly detailed so you can, because we are going to be ruling out other reasons for this, so you need to get a detailed history and find out how often they're having diarrhea. Skincare is really important with these folks because of the excoriation of the perianal area. Again, try to reduce stress as much as you can, diversional activities, television, soft music. Teach them when to seek medical care and the symptoms of their recurrence, and teach them about the action and side effects of the drugs. Again, many of these drugs will increase their risk for infection, so they need to be taught about signs and symptoms of infection so they can seek care quickly. And teach them about the importance of rest and managing their diet, avoiding high fats, avoiding, reducing meat consumption. If they're smokers, they need to quit smoking. And teach them about perianal care and things that can make them more comfortable during their exacerbations.